Hello, this is Dr. Wood, and I will be discussing the two cases for the NSC 800 Summer Pediatric Case Simulation. So the first patient here was a 4-year-old Caucasian male with a cough for 1 week. So some of the differentials that you may have included would have been community-acquired pneumonia, asthma, acute bronchitis, viral URI, allergic rhinitis. Before we get into other differentials, the thing to consider is what time of year are you seeing the patient? If the timing had been appropriate, it may have been flu season, so you may have considered influenza, or the same thing for RSV. Other differentials listed here: bronchiolitis, upper airway cough syndrome, croup. Don't forget about foreign body, tumor, cystic fibrosis, TB. Think outside the respiratory system. Remember to keep your blinders off. It may be a diagnosis that's not within the same system as the symptoms coming from. So congenital heart disease, GERD, sinusitis, pertussis. When you get the chief complaint, it's important to look at every piece of information within that chief complaint. What is the age of the patient? So that's going to be very important as to what the differentials may be based on age, as far as an infant, a young child, older child, college-age student, middle-aged person, elderly. Also, what's their gender? Could there be anything specific to their gender that you need to be thinking about as far as their differentials are concerned? What is the symptom or symptoms? And what's the duration of those symptoms? Is it something acute, something more chronic? So really break down each one of the pieces of information that you receive in the chief complaint to help you come up with your differentials. For this assignment, we ask for 5. However, as you gain knowledge and clinical experience, and then when you get out on your own as an independent provider, you're going to have many more than 5. And then always think, okay, what could this be outside the system in which the chief complaint or the complaints are in? Think about the most common, and then also what would be the most concerning diagnosis is when you're thinking about your differentials. So, we're going to begin that visit with the HPI, and for the PEDS patient, it's important to know who's brought them in and who's answering the questions. So this 4-year-old was brought in today by his parents. And they were stating that he'd been complaining of a cough that started suddenly and worsened over the past week. It sounds like it's deep in his chest. It occurs at rest and is worse with activity. It's productive with green sputum for the past 2 days. Appears to breathe more quickly with activity due to increased coughing. Complains of being short of breath. Symptoms are interfering with activity and sleep, causing him to be very irritable. Causing right lower lateral chest pains for the past day. No radiation. Cough or pain doesn't change with time or day or positioning. There's been no relief. They've tried some over-the-counter Robitussin for children. Treating fever with children's ibuprofen per package directions. No recent ill contacts, and has not been seen by a provider for this current illness. We're going to answer all of our old CART questions and our additional pertinent HPI questions before we move on to review of systems. Remember, we're not going to intermingle these. These are very separate sections. So to address our review of systems questions, we have to think about all of our symptoms that we have listed for the differentials that we have chosen. So your diffs may have been a little bit different than the diffs that I had listed for the top 5. But again, you're going to go through, and if you didn't get an answer for it in your HPI, you're going to ask questions related to your symptoms for each differential and make sure that you cover them all here. Another thing to keep in mind is also we want to know what the temperature max has been. Not necessarily are they just running a fever, but what is the temperature max? And then also hydration status. Time someone's ill, especially if they're running a fever, they're getting some fluid loss anyway with the fever, so we're also wanting to know, is there any additional fluid loss such as vomiting and diarrhea, and then also how is their intake and their urine output, and you want to be very specific so that you can quantify that. So the review of systems, in order to have a good review of systems, you got to remember you have to start out with that strong base that you always hear me talking about. And what I mean by that is you have to have sufficient symptoms and signs listed for each one of your differentials. If you've just got a few scant symptoms and signs, you are not going to truly be able to confirm the diagnosis and refute all others. You know, they're differentials because they all have something in common, that chief complaint. So you really have to be able to have a very extensive list of symptoms and signs so that you can be able to confirm the diagnosis and be able to refute all others, because sometimes, as you've already seen in clinic, there may be more than one thing going on. They could be correlated or possibly not, but you've got to be able to confirm the diagnosis or diagnoses. To get a good review of systems, you've got to have sufficient amount of symptoms for each one of your differentials. So just make sure that you're getting those key symptoms and that you have a very expanded list. As you've seen from the summer assignments that have been related to pediatric cases, it's a little bit different with adults. You know, for peds, it's important to find out what might be related to this visit. I mean, what parts of the prenatal history, birth history, newborn screening, developmental milestones are important, or is this something that I could address during a well child visit, which this child is needing. So prenatal history on this child, that the child did receive regular OBGYN, or the mother did receive regular OBGYN visits without any issues or concerns. No maternal tobacco, alcohol, or drug use when she was pregnant with the child. The child was delivered at 37 weeks, spontaneous rupture of membranes. APGAR scores were 9 and 9. So that gives you a really good idea of just, you know, prenatal exposure and, you know, birth history there. Kind of gives you a good picture of this kid. Newborn screenings, it's important to know your newborn screenings. This is a respiratory complaint. It's important to know that the CF screening on the newborn screening was negative, and that they also had the critical congenital heart disease screening that was normal at birth, where they placed the oximetry on the hand and the foot. Because if we were thinking this could be, you know, congenital heart disease, as far as a differential causing that cough, that would be important to know. Developmental milestones, this child had met developmental milestones all along other than delayed walking. By 18 months, they had some physical therapy that quickly improved his ability to walk. Find out about any type of medication allergies, and in particular, what was the reaction. And this child did not have any history of food allergies. The only thing the kid was taking was the parents were giving him some over-the-counter Robitussin and children's ibuprofen for that fever and cough. There were no prescription medications or herbals. As far as his history, he had an ear infection once when he was 9 months old. And it's important to note that he did not have a history of atopic dermatitis or seasonal allergies or asthma, as this could relate to our differentials and the symptom of cough that's bringing him in. He's not been hospitalized. He's not had any surgeries. His last well child check was age 3, and he was up to date on his immunizations at that time. However, you know that he would be due for a 4-year-old well child check and immunizations. Flu vaccine was in the fall of 2017, so he did not get one in the fall of 2018. So again, not only is it important to find out about personal history that might be related to that chief complaint differentials, but family history plays an important role as well. So it's important to note that there was not a family history of allergic rhinitis, asthma, eczema, or atopic dermatitis, cystic fibrosis, or congenital heart disease, or GERD. Remember, family history, we're going to take it all the way back to grandparents, so parents, any siblings, and grandparents on both sides. So you don't need me to read that here for you, but you can see the family history listed for this child. Social history, again, lives with parents. It's important to know where. They live in an apartment. There is a park nearby to play. No pets in the home. That would be important if we were thinking related to allergic rhinitis. Father smokes outside the apartment, so that might be an exposure, but it sounds like he's not doing that inside the living quarters. Wonder if he's smoking in the car where the child may be. No exposure to alcohol or drugs in the home. That's important to know about peds. Child attends preschool and will be starting kindergarten next year. As far as his diet, he eats breakfast and lunch at preschool through the week, allowed to eat junk food and drink 3 to 4 regular soda or juices a day. Mom cooks meals, but they tend to be in high-calorie, high-fat meals. He doesn't get any regular activity or exercise. He likes to play video games and watches a lot of TV, about 4 hours a day. Social determinants of health. We've learned how important it is to assess for these. He has state insurance plan due to low income. The apartment does have running water, heat and air conditioning. Finances are a strain on the family, and grandparents help out when it is needed. So now we're ready for our objective or our physical exam now that we have completed all of our history components. So we want to start out with the vital signs. His height is 40 inches, which is the 50th percentile. Weight is 45 pounds, which is the 90th percentile. It's important to know that trend when you're plotting him on the growth chart, so he has not had any changes. His percentiles for height and weight have been very consistent. It does place his BMI for age is greater than the 99th percentile according to the CDC percentile calculator for children. Temperature is 101 Fahrenheit. His heart rate is 92. Blood pressure, I had originally forgot to include a blood pressure on the case. It was normal for this child's gender and age. Respiratory rate was 26. SpO2 on room air, it was 95%. So we walk into the exam room and we do a general overall impression. He's lying on the exam table, mildly ill appearing. And then skin in general is pink, warm, dry, no cyanosis. He's got no rashes. Mucous membranes are moist, brisk cap refill, no lesions or eczema. I'll read all this to you. Please feel free to pause the recording and kind of read this to yourself if you would like, or make notes for future documentation of SOAP notes. Let's just take a look at any of the abnormals for time's sake. Let's get down to his respiratory. That's going to be important. No chest deformities. He's got full and symmetric excursion. Occasional cough. Respiratory rate is even, slightly increased. No signs of any type of distress, such as nasal flaring, grunting, retractions, accessory muscle use, hunching. He's not doing any of that. You do hear rails to the right lower lobe, and he does have dullness to percussion over the right lower lobe. This child was not cooperative with bronchophony, egophony, any type of those specific signs related to pneumonia. After we have completed our physical exam, and again, remember we are picking up all of our signs that we had listed in each one of our differentials here under our objective exam. So assess all signs as well. Then we're ready to see if we need any diagnostics or labs. A chest x-ray would not be required if the diagnosis for pneumonia is very clear. However, if you ask for a chest x-ray, the x-ray did show a right lower lobe infiltrate. CBC, again, not required for outpatient treatment as it will not change your treatment plan. Lead screen, if you were suspicious of that, he had a normal screen at the age of 3. If you were in flu or RSV season and you were suspicious of that, you could check a swab, and both of those would have been negative. And a TB risk assessment. If you were concerned for TB, his risk assessment was unremarkable. So after you finish with your diagnostics and labs, this is the time that you look over your information in the middle of the case simulation. Take about 5 or 10 minutes, and then you will come back on be on screen with the facilitator still, and you will present the patient case to your facilitator, just like you do in clinic when you're presenting the patient to your preceptor when you've come out of the room. So you'll start at the very top with the chief complaint and present all the way through. Presenting takes some practice to get that in a good, concise, logical fashion. So I encourage you to even practice this, in front of a mirror or in the car to and from clinic or work, as far as giving a good, concise presentation. You have to be able to refute all other differentials and confirm the diagnosis or diagnoses. So in your SOAP notes, you know that this is the portion where we have you list the differentials again with the symptoms and the signs, and you have to put a positive or negative in front of each one so that you can clearly visualize what it is that you're doing here when we say you have to be able to refute other diffs and then be able to confirm your diagnosis by looking back at all your symptoms and signs. So as you know, this was community-acquired pneumonia. You have to know what the likely organism is in order to be able to treat. Likely organism is strep pneumoniae. Diagnosis is overweight and obesity. His weight by the CDC PEDS calculator, remember, is over the 99th percentile, and it is his single biggest risk factor for heart disease, diabetes, etc. In his history. So again, don't just hone in on the diagnosis from the acute complaint. We always want you to be thinking holistically about your patient encounters. And so this is a big diagnosis for this child and health problems. We want you to also be thinking about other diagnoses and address those as well. But the plan of care for the pediatric pneumonia, first line treatment, since he does not have an allergy to penicillin, would be amoxicillin, 80 to 90 mg per kg per day, divided in 12-hour dosing twice a day. And we're going to use the larger concentration so we have the least amount of liquid. So the amoxicillin, 400 milligrams per 5 mils. If you calculate that out based on his weight in kgs, it'll work out to be 10 mLs or 11.5 mLs BID, depending on whether you're going with the 80 or the 90 mg per kg per day dose twice a day. And you would dispense 200 mLs if you were doing the 80 mg per kg per day twice a day, or 230 mLs if you were doing the 90 mg per kg per day twice a day. There was some question about the information that some students found in Hippocrates about the dosing. Hippocrates had mentioned 3 months to 4 years of age that the max would be 500 milligrams a day. And then from 5 years and older, the max would be 4,000 milligrams a day. So that's a big jump between a max of 500 milligrams a day to a max of 4,000 milligrams a day, with the cut point being 4 years and then 5 years. So we don't know exactly whether this kid might be closer to 5 years, but we do know that he's, heavier than the average 4-year-old. So he could certainly handle the dose, and it'd be very appropriate, the dose that you see here. If you are feeling a little unsure about PEDS calculations, please take a look at the PDF inside the summer course under course documents. There is a pediatric calculation sheet that walks you through several pediatric calculations. And by all means, don't hesitate to reach out to me and we can work through some together, or I can give you some practice problems to work through, because I want you to feel very confident and comfortable when you're calculating pediatric medications and doses and that kind of thing. This child also needs to have continued treatment for fever, so continue the children's ibuprofen as needed for fever, and you can see the dosing that was calculated here for this child based on weight. We want the child to rest, increase fluids, monitor that urine output for hydration status, discuss spread precautions with the family and the child, and follow up in 2 or 3 days to reassess our treatment plan. And we want to avoid cough suppressants. I mean, the child has pneumonia, and we certainly don't want to suppress the cough. Plan of care for this obesity. Remember, it's a very high risk factor for him. He's at risk for weight-related health problems, so he needs some dietary exercise counseling, and we want to individualize this as much as possible. So the biggest problems that I see here with this child is screen time, and that we're consuming a lot of soda and juice. Could his parents take him to the park and play? What other activities could he do? It's best to have none, but if he's currently drinking about 4 sodas or juices a day, then we could maybe cut to 1 a day. That way he can pick one thing that he likes to drink and feel like he still has some control. And then don't forget the 5210. That's a quick little number system to remember, and you would want to instruct your parents and the child, 5 fruits and vegetables per day. We're going to try to get that in. 2 hours or less of screen time per day. Encourage 1 hour of physical activity daily, and 0 sugar beverages. Ocean disease prevention, flu vaccine every fall. Avoid secondhand smoke exposure. He does need a 4-year-old well child examination with immunizations when he's well. Always got to consider red flags or complications. So pneumonia complications, consider and assess for sepsis, especially in infants, meningitis, otitis media. You can develop a sinusitis as well. So remember, you need to assess for complications. Red flags, what should we say to the parents about, have them seen sooner or go to the emergency room, if the child develops any of the following, and you would explain this in, layman's terms. But if they experience tachypnea, dyspnea, retractions, grunting, nasal flaring, apnea, altered mental status, and of course this is not anything they're going to be assessing at home, but if you in the office they had a pulse oximetry less than 90% room air. When should we consider hospital admission? Well, infants less than 3 months, you definitely want to be treating them in the hospital. Infants 3 to 6 months may need to be hospitalized. SpO2 less than 90 to 91%. The child is severely dehydrated, mildly dehydrated, and unable to consume fluids in order to help prevent further dehydration. Moderate or severe respiratory distress, and we mentioned above all the things that we'd be looking for to determine respiratory distress. If the child failed outpatient antibiotic treatment, if you felt like it was unsafe to send them home, if you didn't think the parents would be able to, or just, transportation wise, or they're just not reliable enough to bring the child back for follow-up, if you don't trust that they'll come back for follow-up for reevaluation, would be admission criteria. Okay, what if this patient was allergic to penicillin? Then what would you prescribe for this community-acquired pneumonia? Cephalosporin, 2nd or 3rd generation for 10 days. And what immunizations are required at that 4-year-old well child examination? Look at your CDC PEDS immunization sheet. What would that child be receiving when they come back? And that's listed here for you, what the child would receive at the 4-year-old well child exam, since he's been up to date all along up until that point. Here's some of the anticipatory guidance that's age appropriate that you would be discussing when they do come in for that 4-year-old well child exam. Seat belt, booster seats, never leave alone in the house, or that should say car, not care, car, yard. Avoid play near streets and driveways. Keep medications, cleaning solutions, insecticides locked up and out of reach. Helmet when being out on a tricycle or a bike. Guns, I find out if there's any guns in the home or in friends' homes. Appropriate dental care and eye care. Okay, let's take a look at the pediatric iron deficiency anemia case. This was a 3-year-old African-American male with complaints of fatigue, irritability, and pallor for 2 to 3 months. In developing your differential diagnoses, specifically take a look at the information you have. What is the age of the patient? What is the Ethnicity, does that play a role in what the patient may have? What are the symptoms and what's the duration? How long has this been going on? Is this something acute? Is this something chronic? Is it something within a particular body system? Have I thought about differentials outside of a particular body system? Because as we gain knowledge and clinical experience, we really need to begin to expand our differential diagnoses list, thinking about what are the most common things versus, what are the most concerning things that I absolutely must rule out. Okay, so some common differentials for this chief complaint would be iron deficiency anemia due to age and diet, sickle cell disease due to ethnicity. Don't forget leukemia. That's one of those big things that you wouldn't want to miss. Your asthma and or allergies. Other differentials you may have included would be thalassemia, G6PD, sickle cell disease, plumbism, failure to thrive, type 1 diabetes, hypothyroidism. Again, if you weren't considering leukemia or asthma, make sure you add that to your expanded list of differentials, and you'd want to at least see that the child had a negative sickle cell trait, sickle cell disease, on their newborn screening. We have our differentials with our very expanded list of symptoms and signs. Then we're ready to begin our HPI. So this patient was brought in today. Remember, I said it's important to know who's bringing the patient in and document that, by his grandmother today, and states that they are concerned that for the past 2 to 3 months, he just isn't acting like his usual self. He's been fatigued and irritable. The onset was gradual, but seems to be getting worse. Recently noticed that he looks pale, more pale, seems easily tired and doesn't play as much as usual. He's up until the past 2 to 3 months, he was very active. Now he's been sleeping more than normal, 8 to 10 hours per night, and it's uninterrupted. He seems to be fussier than usual and whines a lot, asks to be carried when they go shopping. They wonder if he's going through just some type of stage or doesn't feel good. He has an occasional tantrum if he doesn't get what he wants, and he is put into timeout for about 3 minutes if this occurs. I can't tell if there's any triggers, as far as what makes it worse. There's not been any new stressors or changes in the family or in the home. As far as additional pertinent HPI, he has not, been ill with anything recently that the grandmother is aware of, and he's never had these type of symptoms before or been seen for this. We have obtained all the information needed from old carts and additional pertinent HPI. Then we're ready to go into a very separate section. Remember, don't blend and confuse your HPI in your review of systems. Didn't get an answer related to a particular symptom in the HPI. Here's where we're going to ask it in review of systems. So I won't read these to you because you know that they're based on your differentials and what symptoms that you have listed for each. Remember, review of systems only includes symptoms, things that the patient or family member would tell you. It does not include signs or things that you would examine for. That's going to be coming over when we do our physical assessment under the objective data. Medical history, again with pediatrics, prenatal history, birth history, newborn screening, appropriate developmental milestones. The mother did receive regular OB/GYN visits without issues or concern. There was no maternal tobacco, alcohol, or drug use. It was a full-term spontaneous vaginal delivery. APGARs were 8 and 9, and that's taken at the 1 minute and the 5 minute mark. Newborn screenings were all negative to include sickle cell. The critical congenital heart disease was normal at birth, in case we were thinking about, cardiac issue being the cause. Developmental milestones, he sat at 6 months, walked by 10 months, off the bottle by 13 months, and drinks from a sippy cup. So you need to know if he has hit those normal developmental milestones all along. So you just have to, memorize those. Prior illnesses, he had 3 episodes of an otitis media when he was in daycare up until age 1. None since the grandmother began to watch him or babysit him in her home. He had bronchiolitis 8 months ago, and he's not had a cough since then. He's allergic to penicillin. That caused a rash. Never been hospitalized, no surgeries, no prescription, over-the-counter, or herbal medications. His last well-child check was 18 months of age. He's up to date on immunizations until he turns 4, and he had a flu vaccine in the fall of last year, 2018. Family history, it's important to know about family history that might be related to our chief complaint and our differentials, but then also some of the chronic diseases that we know are big out there. So I won't read those to you. You can see those here. History, he lives most of the time with the grandmother in the house since both parents are working 2 jobs. Grandma is divorced and child does not see the maternal grandfather. Sees the parents on the weekends. Grandmother does not have support caring for the grandchild. They live on a busy street and he really can't play outside due to that. There's not a park nearby. Grandma says that she spoils him since he is the first grandbaby. He does not have any siblings. There's no pets in the home. They eat out about twice a week. He's a picky eater. He likes to eat pasta and bread. Loves milk, about at least 6 cups in a day, and gets up once through the night for a cup of milk. Occasional juice. He gets pop whenever he wants it. He likes bread, chicken nuggets, and French fries. He'll eat applesauce, bananas, canned peaches, but no green vegetables. Unless Grandma hides those green vegetables inside another food. He'll take an occasional bite of a hamburger. He gets to eat candy when he wants. Grandma smokes outside the home and not in the car. Grandmother drinks about 1 or 2 beers about twice a week. No illicit drug exposure. Parents don't smoke, and there's no alcohol or illicit drug exposure when he's with them. Grandmother lives in a house built after 1990. There's no construction at the home. And thinking about social determinants of health, he is Medicaid insurance. House does have city water, heat, and air conditioning. His height is 38 inches. He's in the 50th percentile. His weight is 29 pounds and 5 ounces. That puts him in the 25th percentile, which is a drop from his usual 50th percentile from his last visit when he was 18 months old. So once you plot those height and weight on the growth chart, it's important to look at what are the normal percentiles or curves that they've been following. Is there an increase or a drop on the height or weight? His BMI for age is at the 2nd percentile. He is underweight. The CDC, according to the CDC percentile calculator for children. His temperature is 97.6 degrees Fahrenheit. Blood pressure is 88/50. Heart rate's 102. Respiratory rate 24. SpO2 96% on room air. Remember, we're doing a general assessment as soon as we walk into the room. He's very cooperative. He's in no acute distress. The child is sitting on a chair looking at a book that's in the exam room. We know that body systems that we examine for is going to be targeted based on our chief complaint and those differentials. So you can see those listed here for you. I won't read all these to you. You can stop the recording and read it or jot it down if you need to. Let's just take a look at the abnormals. He's got marked pallor on his face. Nail beds are pale. A pale nasal mucosa. He has a grade 2 of 6. Blowing murmur along the left lower sternal border, upright and supine. Otherwise, the rest of our exam, as you can see here, was normal or unremarkable. So let's take a look at diagnostics and labs. If you're worried about lead exposure, you could order a lead level, and it was 2.04. Normal is less than 5. If you were thinking hypothyroidism, his TSH was within normal limits. MP was normal, and a CBC was normal other than the values below. So let's talk about these abnormal CBC values. He had a hemoglobin that was low at 8.7, hematocrit low at 25. The MCV is low at 54.1. So we have a microcytic anemia. The MCH is low at 16.4. The RDW is high at 21.3. He's low on his stores. The ferritin is 7. He's really trying to compensate. The total iron binding capacity is high at 500, and his total iron is low at 45. After you are finished with diagnostics and labs, during the case simulation, you'll take 5 or 10 minutes to look over the information that you have obtained from the visit, and then you'll present the case orally to your facilitator, just as if you do when you come out of a room in clinic and present to your preceptor from the beginning. So this child has iron deficiency anemia, and you have to be able to support or confirm that diagnosis and be able to refute all others. So as I said earlier, this is the time in your SOAP note write-up that we have you copy and paste your differentials with symptoms and signs over again and put a positive or negative in front of each symptom and sign. This is due to excessive milk intake and nutritional deficiencies is why we have this iron deficiency anemia. Think about the child overall. He is underweight due to poor nutrition. He had a heart murmur. It's most likely due to anemia, but that certainly needs to be reevaluated once his hemoglobin and hematocrit return to normal. That can't fall off our radar. We need to make sure we reassess that. Let's take a look at our plan of care for this iron deficiency anemia. The child needs some iron therapy. So we're going to calculate the iron dose and make sure that we know how to write that prescription. This is a very scary prescription because the risk of overdose is great, and there are multiple dosings. You know, there's drops, suspension, elixir, etc. So we got to make sure that we're very accurate, and then we always have someone double check our iron prescriptions in the office, another provider. Or call the pharmacy if there's not another provider and have them check it with you. Okay, so plus the elemental iron is 1/5 the amount of the iron sulfate, so it can be confusing. So again, you always want someone to confirm and double check your prescription. So let's take a look. The dosing is 3 to 6 milligrams of elemental iron per kg per day in 2 BID dosing, divided doses. You can pick where you would like to start. It's not well tolerated, so sometimes starting at a lower dose is okay until they see if they get any side effects like constipation or abdominal pain or anything like that. So we're going to use the fair and sol drops when ordering iron therapy. Okay, so fair and sol drops, the elemental iron is 15 milligrams per 1 ml. This one is actually easier because it comes with a dropper and it's less volume. If the kid doesn't like it, then the family can squirt it, into the back of their mouth. So remember I said 3 to 6 milligrams per kg per day. So the child needs 40 milligrams of elemental iron a day if we're looking at the 3 milligrams, and 80 milligrams of elemental iron per day if we're looking at the 6 milligrams per kg per day. Calculating that out based on the child's weight in kgs, it's 1.3 mLs BID for the 3 mg per kg per day, and then you can, calculate how much you should dispense for a month and give a couple of refills. And then for the 6 milligrams per kg per day, it works out to be 2.6 mLs BID, and the total dispense for a month is 156 mLs with 2 refills. So again, take a look at the PEDS calculation sheet inside the course under course documents. I'm happy to work through any calculations with you or give you some more practice ones if you prefer. Just say it one more time. Iron dosing should always be double checked with another provider and or the pharmacist. And that should always be kept up out of reach of children, as far as storage, in a locked cabinet, because iron dosing, it happens. It's very scary, overdosing. Okay, so iron supplement should be given on an empty stomach if it can tolerate it, or with vitamin C, like juice in 2 divided doses. The vitamin C helps with the absorption. Follow-up, They would need to have another hemoglobin and hematocrit and a retic count in a month to make sure that we're on the right track here. Could recheck retic count in 1 week, and it should be over 2 if we have the right diagnosis and the child's getting the medication. If the retic count then needs further evaluation for other causes or etiology, or he's not taking the iron, might be another reason why that retic count wouldn't be up. Also, in 1 month, check that heart murmur. Remember, I said you can't let that fall off your radar. It's most likely due to the anemia, but we have to make sure if it's not resolved, as the anemia is resolving, then we need to refer the child to cardiology. To the parents would be that we want to avoid the iron on the teeth to prevent staining. Give with juice on an empty stomach. Consider using like a straw. Try to increase fiber in the diet because it can cause constipation. He needs more fresh fruits. He needs to wean off milk and get to 2 cups a day. No milk at night. Give him water in a sippy cup, or just go cold turkey on sippy cup at night. Brush teeth before bed and nothing but water after that point. We need to increase our high iron foods. And then, kids at this age can be tough. The principle is that it can take 10 times for one food to get used to the taste. And that's supported by the evidence in the literature. So have him eat 1 green bean, 1 piece of broccoli, 1 piece of meat, raisin for snack. Put spinach chopped up or blended in pasta sauce, as for some specific instructions, for the grandma and parents. Other principle for this age is that they have physiologic anorexia. And if they drink, they fill up on that fluid and then they won't eat. So no fluids 1 hour before a meal, and none on the table until they've eaten. No cookies, desserts unless they eat. This is a picky age, and it's best to get them used to flavors and those textures at a young age before they turn 5, or it's really much harder at that point. Guidelines are we looking at for health promotion, disease prevention? Well, to know the well-child check schedules, we're looking at the American Academy of Pediatrics. To look at immunizations, we're following the CDC guidelines. So this child is due for a 3-year well-child exam. And we want the child, we want the parent, the grandmother, to avoid secondhand smoke exposure, continue with the flu vaccine yearly, and try to help grandma work on issues about giving him, whatever he wants and spoiling him because he's the first grandbaby. We want to present that to her that it's, making him sick. Grandmas want the best for their baby. So, this is hard on his heart. And we want to enlist her help in that way. Okay, let's take a look at some teaching points. What type of anemia is this? Remember, it's a microcytic hypochromic. And how do we know that? We know that because of the MCV is low and the MCH is low. So it's a microcytic, not a macro or a normocytic. And so what are the causes of microcytic anemias? One of them could be iron deficiency anemia is the most common cause. What does RDW tell you about the anemia? A high RDW tells you that there is a wide range of cell sizes. Okay, what if his stores, his ferritin had been high? Then what would be the most likely diagnosis to consider? Thalassemia. Ferritin, or those iron stores, are high. How did we know that this was not a sickle cell or some other hemolytic process? Because retic count is 0.4, so he is not hemolyzing. Okay, so let's think about anticipatory guidance for a 3-year-old. What are some things at a well-child check we'd want to talk about with a 3-year-old? Car seats, never leave alone in the car, house, yard, any guns or friends in your home or friend's home, keeping medications, cleaning solutions, insecticides up out of reach, a helmet when riding a tricycle, supervision when playing near streets and driveways, read and talk to the child, plans for preschool or Head Start, dental care, And then he would be due for another set of immunizations at the age of 4. And what would those be? So make sure we have, we kind of know that CDC childhood immunization schedule and what's due when, in addition to appropriate childhood developmental milestones and appropriate anticipatory guidance for each age. Concludes the discussion on the pediatric cases for the summer case simulation. I hope you find them very helpful. If you have any questions, please don't hesitate to reach out to me.